Welcome back, class. We're going to spend a few minutes now talking about the monopoly model. And just quickly, I want to go back and remind you that if we look at perfect competition, there are many buyers and sellers, homogeneous product, complete information, easy entry and exit, kind of the four main drivers of the competitive market. And while there may not be a lot of monopolies in healthcare due to the integration of health systems, we're getting in some areas pretty close to monopolistic market. And in this segment, I think we're going to talk about monopolies. We're going to talk about oligopolies. But it then I'll just go back to Buffalo, where I worked at Blue Cross Blue Shield. There were two main hospital systems in that whole area. And those two main hospital systems control the market. And as a health plan, you didn't have a lot of alternatives to those two health systems. If I go back to Southern California, when we lived in that San Diego area, it was Sharp and it was Scripps. Yeah, you had UCSD and you had Mercy Hospital, but it was pretty much Sharp and Scripps. And it's somewhat unfortunate, but I can see why healthcare is going in that direction. So you may end up with in some areas, you may end up with somewhat of a monopoly. In Northern California, when I lived in the San Diego area, I worked for HealthNet, worked for United, and you had Sutter Health in Northern California, Sacramento, San Francisco, a lot of those little outlying areas, and they were pretty close to a monopoly, because if you were on the payer side and you were trying to negotiate with that hospital, that integrated hospital system, it was extremely difficult, and the negotiation process it got extremely ugly at times. So may not be the perfect monopoly in healthcare, but with these integrated health systems, we're going to get there fairly quickly. And at this point, let's go back. So we talked quickly about the competitive market. Let's go back to your micro classes and talk about a monopoly. If you look at the market, kind of the definition of the market, there's one seller, there's barriers to entry, and there's a bunch of buyers. If you look at the market demand curve and the marginal revenue curve, it's a downward sloping market demand curve, and the marginal revenue curve is below the market demand curve. It actually has twice. The slope is twice as steep. So if you look at the model, you're going to have the origin. So you got the vertical axis and the horizontal axis. You're going to have price over here. You're going to have quantity on the horizontal axis. You're going to have the origin, and where the market demand curve intersects the horizontal axis, you're going to have the marginal revenue curve, because it's twice as steep. It's going to intersect that horizontal axis halfway between the origin and where the downward sloping market demand curve intersects it. When you talk about price, price in a monopolistic market is greater than marginal cost. And monopolists are price setters. You go back to a competitive market. If you're functioning in a competitive market, you're a price taker. You're not a lot of negotiation. The spot price is what it is, and you can sell as much output as you can produce at that spot price or that market price, because you're not going to be a big enough producer to impact that market price. In a monopolistic market, you are the market price. You're the only game in town. You're the 800-pound gorilla. When you're looking at profit maximization, you produce a level of quantity. So you produce a level of units where marginal revenue equals marginal cost. And then if you want to set the price, you 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 find that point where your marginal revenue and marginal cost curves intersect. You find the quantity down on the horizontal axis, and from that quantity point on the horizontal axis, you just read straight up vertically till you hit the market demand curve. And once you hit the market demand curve, then you read over to the vertical axis, and that gets your market price. So as the monopolist, you are setting the profit maximizing combination of price and quantity. Because of profit, economic profits are always going to be there in the long run. You've got barriers to entry. You don't have other firms trying to come into the market because you have a unique product. It's a unique product. They have trouble. Other firms have trouble coming up with a close substitute. So it's difficult for them to enter the market. If you remember on the competitive market, if you're in a competitive market and you're earning an economic profit, you're going to have firms, they're wanting into that market to get some of that economic profit, and it actually will compete the price down until the economic profit drives to zero. Again, in some of your micro classes, you may have heard people talk about entrepreneurs, and they're like bloodhounds. They can smell profit. And if they find an economic profit setting in a market, they're going to jump into that market. They're going to come up with a substitute for the products generated in that market, and they're going to jump in until they can drive that economic profit down to zero. And then lastly, efficiency, because price is going to be greater than marginal cost, the equilibrium solution is inefficient. And because the equilibrium solution is inefficient, that's where governments have a problem with monopolies. Competitive versus non-competitive model. The competitive model is not appropriate if some firm has market power, and that's your monopoly, or that's your oligopoly, where you've got a few firms have market power. Market power ends up being a price setter as opposed to a price taker. Impact on marginal revenue, price is going to be equal to marginal revenue for a price taker. It's not that way for a monopoly. Price is going to be greater than marginal cost. Monopoly is one producer of a good or service in defined market with no close substitutes. Remember, no close substitutes. Downward sloping demand curve, substitution and income effects drive that downward sloping demand curve for the market. Lowering prices generate more units sold, so marginal revenue is going to be less than price. Natural economies, and when you have a natural economy of scale, or natural economy to scale, it is a situation where the average total cost decreases as output increases. Remember, you've got average total cost as a function of average variable cost and average fixed cost. And the more output you can produce, you're going to continue to spread that fixed cost across a greater number of units. And so your average total cost is going to be downward sloping. Monopolist chooses the prices and quantities so that profits are maximized, where marginal revenue equals marginal cost. Remember, marginal revenue equals marginal cost. To get the quantity and then to get the price, you read straight up to the downward sloping demand curve for the market. Marginal revenue is greater than marginal cost, indicates profits are increasing. Marginal revenue less than marginal cost indicates profits are decreasing. And because price is greater than marginal cost in the monopoly, that's why government entities view monopolists as inefficient, especially from society's standpoint. They view them as being inefficient. Deadweight loss occurs when the value of units produced is less than the opportunity cost of the resources allocated to their production. Impacts society via underproduction. Part of the problem with the monopoly is they don't generate output to maximum capacity. while at the same time they charge a higher price for the output they do produce. And that is a negative impact on society. And then on monopolies, barriers to entry. And they can be cost barriers, they can be legal barriers, they can be technical barriers, they can be input control, economies to scale, it can be a unique production function that and that maintains that market power. And one of the when you're talking about a monopoly, one of the first monopolies that come to mind for most people are De Beers. For years, they had the diamond market cornered. They had gone into the African continent and they had bought up all of these leases for mines, and they were controlling the input side of that equation. And for years, again, they controlled the market. De Beers set the price, they set the quantity, they set the supply. They were the true monopoly. It didn't last, and most monopolies don't last over the long run because now companies are finding diamonds in other countries. They've got artificial diamonds out there now. So, but from my perspective, when people mention monopolies, I think of my cable provider. I'm hung with Comcast. I'm zip code I live in Atlanta. If I want internet, it's Comcast. I can't get Verizon internet. I can't get any other landline internet. It's Comcast, or I do without internet. There's some other options for cable TV and some streaming, but again, I have to have internet to get those. Economies of scale determine a firm's position on the long run average cost curve, decreases as output increases, and lowers cost, allows firms to set lower price for output, discourages competition from cost-effective substitution activities, and limit pricing and price regulation. So the government is providing some price regulations for a lot of these monopolies because the government thinks they would have a better opportunity controlling monopolies. And monopolies, because of their cost structure, and maybe it's because of the infrastructure they have, they can generate goods and services at a lower cost. And in theory, that's better for the consumer, but it doesn't always work out that way. Monopolistic competition implies several firms with minimal market power or barriers to entry. They are differentiated. When I say differentiated, it's the product differentiation. Advertising, quality, location, product drives the ability to raise prices and maintain market share, brand loyalty, and imperfect substitutes. If I think about, so I grew up in Southern Kentucky. Actually, my wife and I both grew up in Southern Kentucky. And about 15 miles, I grew up about 15 miles north of Bowling Green. And growing up, if you had a severe illness, your two options, I mean, there was a city county hospital in Bowling Green, but if you had a serious medical condition, your options were you drove north to Louisville and went to Norton's or, one of the hospitals there, or most people always wanted to drive south to Vanderbilt. Vanderbilt was considered the best opportunity for health care at the time, again, when I was growing up. My guess is in the Nashville market, Vanderbilt still may be considered the premier healthcare facility in the Nashville market. And because they are, and if they are considered the premier, because all of the payers or all of the health plans want them in their network, they may be able, through brand loyalty and advertising and product differentiation, they may be able to drive higher rates with a health plan or with any payer than maybe some of the other hospitals in town. Maybe some of the other hospitals in towns provide the same quality of service, but the perception may be that Vanderbilt is still, and again, Vanderbilt, you hear them talk about it's the Harvard of the South. and but they have a brand loyalty there, and they do provide excellent health care. Economic profits, as we've talked about, attract more firms and reduce overall market power of existing firms. But in a monopolistic model, barriers to entry keep other firms out. Information, and sometimes when individuals, especially consumers in the healthcare market, they they don't want to fool with getting on the internet and trying to find the best doctor, or getting on the internet and trying to scope out which is the highest quality hospital in town. And because of that, and because the cost of finding that information and time and the opportunity cost because you can't do something else, those individuals are called rationally ignorant, and they are rationally ignorant because they just don't want to invest the time that they would have to spend on the internet or calling a health plan or calling some local agencies to try to determine which provider to use. Impacts product differentiation, prices, and quality. And the perception is higher quality goods cost more to produce, but paying average market price drives higher quality goods from the market. You can't provide producers, and in this case, providers of healthcare goods and services, and I'll continue to talk about the national market. If they cannot produce those services at such a price level from the payer side, then it's going to drive those types of goods and services out of the market. And I think it goes back to two chapters ago, I think, when we talked about technology transfer, robotic surgery, laparoscopic, and there's a lot of technological advances out there that can improve the quality of healthcare we see or we receive. But again, if nobody's willing to pay a price above market price, then there's no rationale for a entrepreneur to go through innovation, product development, bringing them to market if it has to be FDA approved. There's no rationale to go through all those steps if they can't drive a profit for their efforts. Advertising and branding can lead to improved consumer information. Sizable expense implies a higher quality product, and that's perception. People, a lot of individual consumers, if they see two products side by side on a grocery shelf and they see that one's a higher price than the other, they automatically assume that it's the one with the higher price is the better product. May not be the better product, but it may have cost more to produce. And the problem with healthcare goods and services, unless you're a private payer, when you go to the physician, I go to the physician, I've got a $10 copay. I know that office visit is going to cost somebody more than $10. That somebody is the health plan that I have. I know it's a $10 charge, but the person sitting next to me in the waiting room, if I were to ask them what do you think this visit is going to cost, they may rattle off, well, I've got to pay $5. I've got to pay $10. I've got to pay $15. That's my copay. And to them, that is the cost of that office visit. Branding builds reputation for goods and services advertising for quality. Because firms are not going to invest in branding on inferior products. They all respect a return on investment. Again, we've talked about firms are in the business of producing goods and services for one reason and one reason only, and that's to make a profit. Bottom line, they have to have a return on investment. They may have investors that are riding them like a rented mule to get a higher return on investment. And because of that, they're not going to go to the effort of branding and advertising if it's an inferior product. You think of all the advertising that you see scattered around Nashville about hospitals, about healthcare, and they're those advertisements cost somebody money, cost that provider money, cost that hospital money, may cost the hospital system money, and they're not going to advertise unless they think it's um, not an inferior product that they're providing, and B, if they think they can draw consumers to that facility to request or to receive healthcare goods and services. I've got, again, my healthcare insurance in Atlanta's with Anthem. It's a Blue Cross Blue Shield consortium. And I can go to a multitude of hospitals. I can go to, I can pick out a primary care doc out of their network. And in most cases, if you look at the Atlanta area, it doesn't matter whether it's Anthem, United, Cigna, Aetna, whomever it is, the network for all of those payers is going to be pretty much the same. They're all going to have pretty much all the hospitals. They're going to have pretty much all the medical groups. Some of the medical groups, aren't accepting patients. And if I look at the national market, if I'm talking about Tennessee Blue or again, all your national payers, they're going to pretty much have all the hospitals and all the provider groups in the national market. It's just a matter of selecting that health plan that you're comfortable with. And then from their network of providers, find a provider that, maybe the driving decision, is, again, when we're talking about microeconomics and consumers, we're constantly making choices and making decisions. It may be maybe something you've seen on TV. It may be because they happen to be the closest to where you live. It may be they happen to be the closest to where you work. I mean, there's a lot of rationales as to why you choose a particular physician or choose a particular hospital to go to. Anti-competitive behavior via branding and its habit versus informed purchases. Brand loyalty via advertising is persuasive rather than informative and more perception than actual differences. New market demand versus stealing from competition. And you see that a lot. We'll go back to social media. So they're social media outfits coming and going. And rather than stealing competition from the existing ones, they're trying to develop a new market demand for this, social media platform. It's going to be the greatest thing since sliced bread, and that's the way they advertise it. And it's the same thing in healthcare. They're not so much trying to steal. Vandy may not be trying to steal from St. Thomas, or Meharry may not be trying to steal from Vanderbilt as far as stealing from the competition. They're trying to grab new market demand, trying to bring it's more cost effective to grab new market demand and bring it in to a healthcare organization, at least on the provider side, than it is maybe trying to steal from a competitor, especially one that has a lot of brand loyalty. Product differentiation and advertising can manipulate the demand for a product and consumer preferences. Again, you've got things like public health and cigarettes. That's driving a lot of healthcare goods and services. And product differentiation and advertising, it can manipulate the demand for a product, in this case, healthcare or consumer preferences, and public health through their advertising and information that they provided to consumers have actually driven down the demand for cigarettes. Product differentiation usually talks about artificial wants. You've got habit buying. You've got some people, and also the barriers to entry. You've got some people that I've got neighbors here in Atlanta. You think they're going to go to Lidl? You think they're going to go to Aldi's to buy groceries? Think they're going to go to Walmart? They're going to go down the street to Kroger's, or they're going to go down the street to Publix. They're going to the name grocery stores. Same thing with individuals that, and in the Atlanta market, we've got BJ's, we've got Costco, we've got Sam's Club, same box stores that you have in the Nashville area. And you have most people that are, it's Costco or none at all. You've got a few that they like Sam's Club better. You've got even fewer of those that like BJ's better. But you get this individuals that you're habit buying, and you're going to have the same thing in healthcare. I don't have any idea what the quality of healthcare is at Meharry, but or at St. Thomas or at maybe it's TriStar. Maybe it's TriStar at the hospital. But a lot of times you talk to people in Nashville and they want to go to Vanderbilt. They want a Vanderbilt physician. They want their inpatient or ambulatory surgery. They want it done at Vanderbilt. Where at one of the other facilities, the quality may be just as good, but you've got habit buying. You've got brand loyalty to Vanderbilt, and it's perceived versus real value. It is difficult to break that brand recognition and that habit buying. And from a consumer perspective, or at least, and I feel like I'm a fairly rational consumer, I want variety. I want prices. I want to be able to do my grocery shopping wherever I want to. I also want variety in my health care. I want to be able to have a health plan that I've got a primary care doc, it's $10. I've got also a PPO, it's a provider organization that for $40, I can go to see any doctor I want to that's in Anthem's network. I can self-refer myself to any of these other physicians for $40. And that provides me the variety that I'm looking for when I'm looking at healthcare goods and services. We're going to talk just a few minutes about oligopoly markets. We've been through monopolies, and oligopolies, it's if you've got on one end, you've got, perfect competition, and up here on the other end, you've got monopolies. Then in the kind of closer to monopolies than perfect competition, you've got oligopolies. And it's a few large firms that have barriers to entry, maybe multiple firms, but many are price takers with limited market power. It depends on the market you have. And if I think of, usually you think of oligopoly as, the Russian oligarchs. So, a few businessmen with the fall of the old USSR jumped into the business world and generated, billions of dollars in profits. And so a lot of people, when they talk about oligopolies, they think about the Russian oligarchs. But you can also have oligopoly markets. And I'll go back to healthcare in San Diego in that Southern California area. Scripps, Sharps, the two 800-pound gorillas in that market. They were driving on the payer side. They were driving access. They were driving quality. They were driving price in the healthcare market. You had Children's Hospital, you had Mercy Healthcare, and you had University of California at San Diego Medical Center. But for the most part, everybody in town went to Scripps or Sharp for some services. They were the big players in every payer's network. And then you had the other hospitals that are in there too, but prices were driven by these two integrated market systems in that San Diego market. And that's why Dewars talks about dominant firms must be sufficiently sized and limited to number so that pricing decisions by one dominant firm impacts the pricing decisions of the remaining dominant firms. If I think about another example, and this is kind of outside of healthcare, if you've ever been to Napa Valley, and it's the wine growing region in Northern California, you have Opus One, you have Silver Oak, they are the big dogs in kind of the market there for Cabernet. Cabernet's a great variety. It generates red wine. But what you also found in that California market, you had some kind of and I always thought it was collusion. Would never been able to prove it, but you had basically three prices of Cabernets. You had kind of a tier that was about $30 to $40. You had another tier of bottles that kind of the in that 50 to $80 range. You had another that was kind of that $90 to $120 range. And then you had Opus One and some of the others that were above that. But to me, every winery there kind of had three prices on their Cabernets. They had kind of this, bottom tier, middle tier, and upper tier. And that's what you'll see a lot of times in healthcare markets is you have kind of tiered pricing tiers. And in my experience in developing networks for health plans and in negotiating contracts from one market to the next, you will actually see similar type tiers. You will see certain hospitals that going into that you're going to be able to get a really price competitive rate from them. You've got kind of a middle tier of hospitals that it's going to be a little more difficult to get that rate from them, but you'll eventually get it done. And then you've got this upper tier, and it's going to be really tough to get the rates you want. Not impossible, but you're really going to have to work hard to negotiate those rates that you want. So that's where you have this kind of oligopoly concept, and that you've got kind of the predominant health plan or the predominant providers in a given market kind of setting the price structure for not only themselves, but the other firms within that market. And collusive oligopoly implies that dominant firms cooperate on price and output, maximize profits by collectively acting like a monopoly. And that's what you saw in Southern California with Scripps and Sharp. It was almost, you thought they were colluding. You would have never been able to prove it, but it was just, you just knew that they were going to set the market and everybody else was going to fall in line. Collusion may be overt. Firms meet formally for prices and market shares, or tacit, informally set prices with a market price leader. And especially in Southern California, the CEOs, the CFOs, the COOs, presidents, whatever term you want to use, they were all members of a country club, members of Kiwanis, Lions Club, went to social events together, and as a health plan, you would never be able to prove it, but you knew when they were out playing golf at the local country club that they were talking business out on the golf course. They were talking about, health plans, and, how big of jerks the negotiators were on the health plans, and kind of here's the price that we need to set. We need all kind. You knew this kind of talk was going on. Again, you're never going to prove it, but that was more of a kind of a tacit approach. They were having fun playing golf, and okay, so if they had a little business, they talked on the golf course, that happened. On the overt, it's more along the lines of meeting formally, and most healthcare providers aren't going to meet formally and talk about setting prices. They're going to have some sidebar conversations and talk about, setting prices. Now, also that, healthcare on the payer and the provider side, you have individuals moving, work on the payer side for a while, they'll move to the provider side, work on the provider side for a while and move back to the payer side. And so you have a lot of pricing information flip-flops back and forth with this shifting of healthcare professionals from one side to the other. But there's also this tacit discussions that go on, and that's just the cost of doing business. And the last bullet on this particular slide is the one that's problematic. Burden of proof with respect to the Sherman Antitrust Act and overt collusion Tacit collusion has difficulty in setting prices, cost of production, common price, barriers to entry, negotiating, monitoring cost, competitive oligopoly. So tacit, it's really difficult to swap. I mean, you can talk about information, but how much of it's retained? You're not passing spreadsheets back and forth to each other. In a formal setting, you can have PowerPoint slides and you can pass information around. But the burden of proof, as far as overt collusion, it is really difficult to actually prove it unless you just catch somebody in the act. And with that, we're going to stop there for a few minutes. We're going to come back, and I think this is going to finish it up with the third segment. So talk to everybody in a few minutes.